You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for October 9th, 2020. This week, COVID, science philosophy, left main coronary artery disease, empagliflozin, and other comments on the SGLT2 inhibitor class. Start with COVID. It is still bad. 3 quick notes. New England Journal of Medicine had 2 important studies published yesterday. One from the recovery group in the UK, a 4,500 patient RCT of hospitalized patients with COVID found no mortality benefit with hydroxychloroquine. No subgroup had even a hint of benefit. Of course, it's good to know that HCQ does not help patients that are ill with COVID, but more important here is the epidemiology. The only way to know if a non-parachute-like treatment works is randomization, so kudos to the researchers. Number 2, New England Journal of Medicine also published the 28-day results of the NIH-funded adaptive RCT called ACTT1 trial. Recall that the 14-day results found benefit in a shorter time to recovery, and death was numerically lower in the remdesivir arm. But the p-value was not significant at 0.05. Now, in the 29-day and final report, the end results were similar. There was an improved time to recovery, and again, the 27% relative risk reduction in death did not reach significance. The confidence intervals for mortality ranged from a nearly huge 0.52 to 1.03. In other words, there could have been a 50% reduction in death with this drug or a 3% increase. In other words, we don't know whether the mortality reduction was due to chance. Now on Twitter, you could see people who dichotomized the result. Essentially, they said it wasn't significant, so remdesivir does not reduce death. And I think I used to think that way too, but not anymore. If you think like a Bayesian, you have to consider the nearly 4% absolute risk reduction in death given the other information. Making you think it was real and not a chance finding is that the drug has documented antiviral activity, and time to recovery was so much better in the 14-day and 28-day results. Now, making you a little worried that it was due to a chance finding was the Wang et al. Paper in Lancet, which found no mortality benefit in a remdesivir RCT. The teaching point, I think, is that the DSMB, the Data Safety Monitoring Board, met after a total of 482 recoveries that exceeded the estimated number of recoveries needed for the trial, and 81 deaths had been entered in the database. So the DSMB had a super result in time to recovery and a close to significant result in mortality. It was the middle of a pandemic. They chose to stop randomizing remdesivir. And I totally understand that decision. But had they let more patients recruit, they would have increased or potentially decreased confidence in the mortality signal. Now, I found the JAMA paper from 2010, a systematic review and meta-analysis, that found that truncated RCTs were associated with a greater effect sizes than RCTs not stopped early. The difference was independent of the presence of statistical stopping rules and was greatest in smaller studies. The third point to make about COVID is, after our president famously received a monoclonal antibody infusion and then seemingly recovered, social and regular media has exploded with enthusiasm, and that includes a Wall Street Journal opinion piece from Dr. Scott Gottlieb occurred this morning, and this editorial is just glowing. And 2 companies that make these monoclonal antibodies have put out press releases saying that their products look great. But that is all the data I can find by press release, nothing else. This is crazy. While I hope this drug works, I could find no human data published with clinical endpoints. I couldn't even find preprints of clinical data. Now, the first two papers, the hydroxychloroquine and remdesivir paper, show exactly how we should learn if our treatments work. COVID is a fairly short disease, and proper trials could be done quickly with these monoclonal antibodies, and that is the only way to know if it works. Second topic is a note on critical appraisal in general. Now, a number of you have emailed me and spoke with me about the critical appraisal on this podcast. And the gist of these comments is to thank me for pointing these things out, but also to say, how can a regular practicing doctor do this? It takes time and skills and a lot of stuff we can see after you point it out. Let me answer this question. First, I'd say that critical appraisal is hard. It took me years to get where I am now, and to be honest, I consider myself hardly an expert. So critical appraisal does indeed take effort, but it's worth it. Second, and I think this is the absolute most important thing to remember, medical progress is really slow and hard. That something does not work should be the Bayesian prior. It's not cynical, it's reality. The null hypothesis is most often the correct one. Now, 95+% of cardiology is not PCI for STEMI or pacemaker for heart block. Much of what we do has really small effects. And even things in guidelines backed by RCTs have very small effect sizes. And the vast majority of things that are recommended in the guidelines have no RCT evidence. Now consider something that has a 20% relative risk reduction and a 1% absolute risk reduction in major adverse cardiac events. That is the average effect in well-selected patients who are cared for in the confines of a clinical trial, the best case scenario. What is the chance that your patient in front of you will enjoy that same 1% reduction? Well, you have to multiply 0.01 times another small fraction, and so the fraction gets even smaller. I don't mean to depress you, but it helps to have the prior that most stuff we do either does not work, or if it does, it has very small effect sizes. Next topic is the EXCEL trial. Again, the ESC, European Society of Cardiology, and EACTS, the European Association of Cardiothoracic Surgery, announced this week that they will review their joint recommendations for revascularization of patients with left main coronary disease. Now, obviously, this stems from the controversies surrounding the EXCEL trial, which I've discussed last week and on previous podcasts. The guideline issue was that in 2018, European guideline writers based their recommendation for PCI for left main coronary disease on the 3-year results of EXCEL that was published 2 years earlier in 2016. And the big issue was that in light of the 3-year EXCEL data, the old guideline document upgraded PCI of the left main to a Class 1A indication for patients with a low syntax score and gave it a Class 2A and 3 recommendation for those with intermediate and high syntax scores. But as I discussed last week, reports from the BBC Newsnight program, along with basic critical appraisal of the EXCEL data, caused the Surgical Council to withdraw its support for the left main chapter of the guidelines. Journalist Patrice Wendling wrote it well in her news piece, quote, "Several subsequent publications, including a recent post hoc analysis zeroing in on how MI was defined in EXCEL, have failed to quell the controversy. And now the two groups will work together, and the collaboration will include completely fresh people involved. They will strive to make it completely independent." To me, this is an important step forward, and I hope for two things. One, that they get the specific recommendations for left main disease sorted out, but perhaps more importantly, the collaboration will serve as an example of independent adjudication of science. My bias about guidelines are this, that they should include many fewer content experts and many more independent clinicians and method specialists. Content expertise is not unimportant, but as important in a guideline is having clinicians with fewer preconceived ideas and no dog in the fight. Next topic is empagliflozin. The Emperor Reduced trial was still simmering after its presentation a month ago at ESC and its publication in the New England Journal of Medicine, and we already have its first post-hoc analysis. Now recall first that the Emperor Reduced trial was a large randomized controlled trial of EMPA versus placebo in patients with heart failure with reduced ejection fraction who were on guideline-directed therapy already. EMPA reduced the composite of CV death or heart failure hospitalizations by 5% in absolute terms. Most of the benefit was driven by fewer heart failure hospitalizations rather than CV death. Now, in the main trial, the EMPA effect was seen in patients with and without diabetes. One important subgroup that was not shown in the main trial was the effect of EMPA in patients currently taking the ARNI drug sacubitril valsartan. At the Virtual Heart Failure Association sessions, the Emperor Reduced PI, Milton Packard, presented the results of this subgroup. Now, of the nearly 3,800 patients in the main Emperor Reduced trial, about 19% were taking sacubitril valsartan at baseline. And the primary endpoint of CV death or heart failure hospitalizations fell by 36% relative to placebo in patients who received EMPA on top of sacubitril valsartan, and by 23% relative to placebo among the patients who received EMPA on top of a different type of RAS inhibitor drug. Now, the p-value for interaction was not significant. EMPA was also effective for improving a quality of life measure in patients compared with placebo, regardless of the type of RAS inhibition used. And for all four outcomes, the point estimate of empagliflozin's benefit was higher when used with sacubitril valsartan. Now, as nicely laid out in Mitchell Zoller's news coverage, the trial discussant, who is a biostats person, said that you can't say empagliflozin works better in the ARNI group, but rather the current conclusion from this data is that EMPA's effect overall is not diminished in the ARNI group. Now, this yet unpublished abstract makes the podcast because it's an important question we will face in the clinic. For instance, sacubitril valsartan has a lofted status in the minds of doctors. We think, oh yes, I got my patient on the big new drug that is shown to be very effective. It's brand name, it's expensive, it's hot. Well, here comes another hot drug, the SGLT2 inhibitor drugs. Should we add 2 hot new drugs, or is 1 enough? Now, this analysis suggests that EMPA still stands to benefit in patients even when they are on the big guns of heart failure therapy. I know I sound really positive on this class of drugs, but we now have 2 large randomized controlled trials showing significant benefits in patients with heart failure with reduced ejection fraction. We have a cardiovascular outcome trial in patients with diabetes and shows reduction in CV outcomes, especially with empagliflozin, but also canagliflozin in the cardiovascular outcome trial called CANVAS and the CKD trial called CREDENCE numerically reduced CV mortality and overall mortality, but it did not quite reach statistical significance. And now we have DAPA-CKD, a trial in patients with chronic kidney disease. Regardless of the presence or absence of diabetes, the risk of a composite endpoint of a sustained decline in estimated GFR of at least 50%, or end-stage kidney disease, or death from renal or cardiovascular causes was significantly lower with dapagliflozin than with placebo. So, ladies and gentlemen, enough is enough. I had my first. I skidded out of my lane, and I stopped the patient's DPP-4 drug and started dapagliflozin. The final issue with these drugs is whether or not it's a class effect. This has come up here at our hospital, whether they have a class effect or whether we should stick with the drugs studied in the trials. Now, of course, it would be easier for hospital formularies to not have every single drug or to have just 1 or 2. But remember, in June of this year, the VERTIS trial of erdagliflozin versus placebo in diabetic patients found no reduction in CV outcomes, though a secondary endpoint of heart failure hospitalizations had a 30% reduction. Last month on Twitter, nephrologist Christos Agropoulos sent out an informal meta-analysis of the big SGLT2 inhibitor trials. I'll link to it. And what you find from this meta-analysis is all-cause death, CV death, heart failure hospitalization, and worsening renal function all looked better with these drugs. Now, we have this class effect debate in heart failure, Remember, in heart failure with reduced ejection fraction, metoprolol XL, carvedilol, bisoprolol have the only ones been studied in RCTs. Now, it's hard to believe other similar beta blockers would not exert similar effects. Same with ACE and ARB. ACE inhibitors have much stronger data in heart failure than ARBs. Captopril, ramipril, porodopril all have strong post-MI data. And of course, enalapril for class 4 heart failure. And we give the other ACE inhibitors a pass for heart failure, but not so much with beta blockers. It seems a little inconsistent to me. And for the ARBs, the strongest data for heart failure or MI with left ventricular dysfunction is for candesartan, the CHARM studies. Irbesartan, who knows? Losartan is a 0 for RCT level evidence. And valsartan's main claim to fame is that it was equivalent to captopril in Valiant. So I really don't know the answer about class effect on SGLT2 inhibitors. I don't know if I'm being too positive with these drugs. I don't think I am. I'm soliciting skeptical thinkers to tell me if I've erred on this drug class. Am I wrong? Let me know in the comments on the podcast or on Twitter. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, it really helps to give us a rating or take the time to write a short review or tell your friends. That way others can find us. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org on Medscape.